Right. Good afternoon, everyone. My name is Rahul Chakrabarti. I'm from Melbourne. And thank you, first of all, for coming to our session, which is on advances in ophthalmic education. Where are we at in 2022? And it's, I think, an important topic given our college's role is in accreditation and training. So I'm privileged today, and I'll introduce my panel members in more depth, but I have Dr. Callum Jin, Dr. Nicholas N. Wright, Dr. Jacqueline Belts, and Dr. Tom Campbell. So I thank them for coming. Just before I start, I'd like to acknowledge that the Royal Australian and New Zealand College of Ophthalmologists, members and participating guests wish to acknowledge the Aboriginal and Torres Strait Islander peoples of this country, sovereign custodians of the country. We acknowledge the continuing presence and their contributions made to the college and the communities we work in. We will respect past elders and communities and will continue to live, work and interact in a respectful manner with present and future elders and communities. And the RANZCO Reconciliation Action Plan reflects the messages of its First Nations engagement. The first speaker, which I'd like to introduce, Dr. Callum Jin. Callum is one of the hospital medical officers at the Royal Victorian Eye and Ear Hospital in Melbourne this year, and he's just submitted his Masters of Medicine through Sydney University treatise in ophthalmic education. And Callum will be talking about knowledge, attitudes and practices of virtual reality simulation in Australian and New Zealand trainees. Thanks, Callum.
Thanks, Rahul. I'm Cal, one of the residents, as Rahul just mentioned, and I'll be talking about training knowledge, attitudes and practices towards virtual reality simulation. So we set out to find what the attitude of the first-year ophthalmology registrars was towards ophthalmic virtual reality education. And this question is the first of a few that are the components of a larger study. So we know that virtual reality simulation improves complication rates and is shown to reduce the likelihood of a posterior capsular tear by 38% in novice surgeons who'd previously had experience utilising virtual reality simulation compared to those who hadn't. We also know that it's able to provide transferable skills to the operating theatre, and a number of the modules have been externally validated. And so while its ability to reduce operative complications as well as provide transferable skills to the operating theatre is well known, the role of attitude in the attainment of this is not. So why attitude? So attitude is a psychosocial construct that has implications for self-regulation and motivation to engage in a learning task. From educational research, we know that a positive attitude towards schooling and education is both correlated with and predictive of students' academic achievement. So this was our approach. So our methods involved utilising a mixed method survey that comprised of baseline statistics, confidence-based questions, and attitude questions. The survey was provided to the first-year registrars prior to the commencement of training and is currently being repeated. The data has been initially analysed utilising basic descriptive statistical methods, and in total we had an 83% response rate, with 88.9% of those who attempted the survey completing it within its entirety. So here are some of the baseline statistics of the first-year registrars. So 77.8% were male and 22.2% female, and 40% scored 3 or higher on the RANZCO Rural Regional Calculator. 52% had any previous surgical simulator use, and just under 12 hours spent utilising it. 87.5% had previous experience in cataract surgery in any capacity, including observing, assisting, or being primary operator, and 22.7% had experience in that primary operator position. 95.8% had any ophthalmic surgical experience at all. They had a total of 260 hours, average time in any operating theatre in any surgical capacity. That being said, there was a number of registrars who had quite a considerable amount of time within the operating theatre. So the trainees surveyed believed that virtual reality simulation would improve some theatre skills, including reducing levels of complications in live surgery, developing clinical decision-making, and enhancing patient safety. They also believed that virtual reality simulation was able to increase both preoperative and intraoperative confidence. And as a learning resource, the trainees agreed that it offered a valuable learning strategy, provides a realistic learning environment, makes learning more engaging and easier, as well as helps to retain knowledge. Interestingly, there was a significant decrease in ophthalmology trainees who believed that virtual reality simulation would continue being useful during basic training compared to those believing that it would be useful during both basic and advanced training. And this was consistent across all baseline statistics, including gender, rurality, previous surgical experience, and hours of computer games or musical instruments played. We asked that question as a sort of a proxy for previous experience in deliberate practice. So what does this mean? So we know from the data from the last few slides that the first year registrars generally believed that virtual reality simulation was useful, that it was able to help them upskill and should help them with live surgery. A positive attitude towards a learning topic is both correlated with and predictive of academic achievement, and this is independent of cognitive and affective factors, including IQ, working memory, general attitudes, as well as anxiety. Secondly, ophthalmology trainees are unsure of the utility of virtual reality simulation as they proceed through their careers. There was a significant decrease in the valuation of virtual reality simulation the further along in training trainees were. A negative attitude towards the learning topic, however, has been associated with reduced cognitive flexibility towards problem solving, as well as worse academic outcomes. And this may impact engagement with virtual reality simulation as the trainees proceed through their training. And thirdly, there is the concept of deliberate practice. Deliberate practice is the breaking down of a complex, or in the context of surgery, is the breaking down of a complex surgical task into smaller parts and practicing those individual components to build up to the whole. And there is growing evidence for the use of deliberate practice in improving surgical performance and developing expertise. There's been previous studies within the laparoscopic surgical field showing that individualized deliberate practice utilizing virtual reality simulation leads to improvements in operating theatre outcomes. Multiple studies have shown that improvements in surgical skills are related to case volume. However, pure task repetition has been shown to lead to a plateau in the improvement of skills before maximal levels are achieved. Deliberate practice has been shown to prevent this plateau and assist in expert formation if used consistently and regularly. This occurs as deliberate practice targets these specific areas of weakness and improves specific steps within surgery, unlike repeating the task at full. And the attitudes discussed will likely impact the ongoing engagement with virtual reality simulation, and later in careers may prevent the utilisation of virtual reality simulation as a tool for deliberate practice. So in conclusion, this study provides an understanding of the attitudes of ophthalmology trainees towards virtual reality simulation. Their view of virtual reality simulation is generally positive. However, the role of virtual reality simulation as they progress through their training into careers as consultant ophthalmologists was not as clear. And we believe that this will likely impact training engagement with virtual reality simulation as they proceed through their training. Virtual reality simulation provides ophthalmology and ophthalmologists with a unique opportunity to engage in deliberate practice and hopefully develop further expertise within cataract surgery. Clear communication of the potential role of virtual reality simulation, deliberate practice, as well as expertise theory will hopefully increase engagement and allow for creation of expertise as trainees continue to progress through their training. Thanks. Let's go references.
Thanks, Callum. In the interest of the flow of the session, we might reserve questions, if possible, for the end. So I'd next like to introduce our second speaker, Dr. Nicholas Enright. And Nick is the current glaucoma fellow at the Eye and Ear Hospital, and we're also privileged in the sense that he was the first cohort of registrars trained using virtual reality training at the Eye and Ear Hospital since 2018. And so Nick will be talking on Back to the Future, reflecting on his journey to now fellowship using virtual reality simulation. So thanks, Nick.
Thanks, Rahul. Well done, Cal. It reminded me, I presented something similar to Cal when I was in first year, a survey on the views on the simulator training in my cohort. So it's interesting to reflect upon that now in fifth year as the glaucoma fellow. Well, good job. This might help complement that talk. I just wanted to echo and support the acknowledgement of country that Rahul said before. So in first year, I remember when we were starting and we were given a very comprehensive timetable of our sort of organised surgical training with Jackie Belts and Rahul were both equally important to our training in the first and second and ongoing years. And you can see how many sessions were organised at that time, each with a consultant coming and spending their time teaching us something. This was also augmented with some wet lab work and some virtual reality work, which was new in my first year, which was very, very exciting for all of us, really. We all really were looking forward to using it. we're all given a copy of Phaco by Barry Siebel, which helped us get through a Phaco exam in second or third year. And this is the simulator setup that we had 2 of these in the wet lab, and this is some of the wet lab setup that we had too. So give you an idea of what the sim is sort of like. This is a video from me in first year, and I'm using the Rexus as an example of the usefulness of this tool. It really, in particular, I think most people agree that it's an excellent way of learning how to do a Rexus before you start doing that in real life. And it's very fun. It's interesting watching this back because I think I can tell it's me doing it still. You know, it's slow, it's a bit ponderous, struggle with grabbing it at times, running out a bit at the end here. But my DNA is like still in how I perform this Rexus. And it's honestly not that different now in real life. Maybe it's a little bit faster, I don't know. So I thought,
Stretch out with your feelings.
this is how it felt in first year.
You see? You can do it.
I call it luck.
In my experience, there's no such thing as luck.
Look, good against remotes is one thing. Good against the living, that's something else.
So Han Solo was skeptical of the use of virtual reality training, which I think a lot of different ophthalmologists and may have had that view at some time, and we're still learning about this and how useful it can be. These are the results from 2018 that I just wanted to re-present. So I asked my cohort, how difficult for you at about 2/3 of the way through the first year is each stage of cataract surgery? So all of it's hard, and the Rexus, hydrodissection, sculpting, all equally hard. We found the whole thing quite challenging. And then I also asked how much had VR training helped with each stage of this. So the front runner is Rexus there. And interestingly, then IA Cortex was also very useful. And I think in hindsight, the Rexus has really been quite improved with this, but it doesn't necessarily explain the 38% reduction in posterior capsule rupture, which I found really interesting actually. This is my recent survey that I performed on the cohort of 5th years and 4th years at the eye near at the moment. And I just want to talk about this slide for a sec. I asked them how important was each component of your surgical training? And you can see supervised theatre time clearly is the most important thing. And then there are 4 pillars that seem to really support this. We're starting to really appreciate unsupervised theatre time that comes in 4th and 5th year, talking to mentors, our first year formalised cataract surgery training, and then there's virtual reality simulation. Some of these people may not have used that VR training for a year or 2 before answering this survey. Wet lab is still very important, and conferences are also useful. I asked some more questions here. I asked them, if you could have gone back and done more of some of these things, you can choose several, what do you wish you had done more of? No one said more simulator training. Some people said wet lab training, spent more time in theatre after hours, more formal training at conferences, and recording more cases, which was interesting. And a few people who answered this were comfortable with the amount of training they had done. So the simulator training is available to us, which is good, and we could do it as much as we really wanted to. When do you think most of your surgical learning happened? 1st and 2nd year, and then 3rd and 4th year. But the formative years really are in 1st and 2nd year. So just to recap some of that, simulator training was an important adjunct in early training, particularly for Rexus. We were satisfied that with simulator training and felt it had a meaningful impact on our surgical training, more significant to some people than wet lab. We were provided enough access to it, and people wish they had recorded more cases. I just thought I'd ask a few more things while I was surveying them regarding prior surgical experience before commencing RANSCO training. A lot of people didn't think previous surgical experience mattered. Some, very small amount, thought it mattered significantly. Everyone else was in between. During fourth year, if a surgeon performed surgery in a different way to you, how do you like to absorb that? How do you like to learn that? Some people just like to start by observing them completely, but generally, we're all interested in learning things by doing it, and we're confident we can perform things with advice from the surgeon. I asked the cohort, how difficult are these cases for you now? Routine cataract was less than 10 out of 100. PXF, small eye, white cataract were similar. But zonular instability is still a pitfall for some of us, most of us. Clear lens extraction was straightforward, and IOL explantation exchange, and it's probably due to exposure to that problem. Do you think there was too much emphasis on cataract surgery? It was about 50-50. I think that's difficult to get around because we need to do a lot of cataracts in our training, and they're more available to other subspecialty surgery. During a routine cataract list, would you prefer that your supervisor scrubs for all of them? No one wanted that. People like to generally play it by ear. Do you think unsupervised operating is useful? I think most people think yes, at this stage now it is. There's a comment saying there's a lot of skills to be learned by being by yourself and problem solving by yourself. And it's also advantageous to be at the eye and ear because there's normally a specialist nearby. So it can be a good setting for routine surgery. Are you enjoying surgery more than at the beginning of your training? Most people said yes. So zonular instability and IOL exchange are considered the most challenging of problems. Unsupervised theatre and independence is valued by the trainees in fourth and fifth year. General feedback is that there's a strong emphasis on routine cataract surgery, not enough complicated cataract and subspecialty surgery, which is a difficult problem to overcome. Operating becomes more rewarding and fun as competence grows. Thank you very much.
So thanks everyone. So my name's Rahul. I've taken over this year from Dr. Jacqueline Belts as Director of Training in Melbourne. And this afternoon, I'm going to talk to you about a structured approach for returning to cataract surgery after a break. And it's something that we've faced imminently in Melbourne in the last few years. As you're aware, we had the strictest lockdowns in the world due to the pandemic, and we saw headlines such as those you've seen there. So elective surgeries paused, and then on again and off again, and changes to non-urgent surgery. And there was a publication from my colleagues at the Royal Melbourne on the impact of ophthalmic surgery in Australia. We saw the volumes significantly decline, and that presents its own challenges, both from a purely motor skills aspect of finding your feet again, but also the cognitive skills. And many of the patients who then get put back onto the list have very advanced cataracts. So finding your bearings again in terms of clinical decision making and leading up to the execution of surgery, managing complications. And as you can imagine, that can lead to secondary issues such as stress, anxiety, apprehension. Nick talked on this about deliberate practice. Deliberate practice is a concept which you break down a big task into its individual components, and you can actually train that. And you can train it both from a technical skills perspective, but also the mental imagery and the mental planning that goes behind it. And returning to surgery also requires a safe, structured approach for transitioning back. So you can't just get on the horse straight away. So the aim of this was really to develop something that is a template for individuals of all levels of experience, whether you're a registrar, a fellow, or an experienced consultant, a structured way to return to surgery, and I'll go through that. And I'll just say that we've now made this into a RANSCO CPD approved activity, so the college was very supportive of this. And I'd like to acknowledge Dr. Belts for her support in this as well. So expertise and deliberate practice. I would all encourage you to read this paper. It was one of the best papers I've ever read by Anders Ericsson, who was a psychologist. He passed away a couple of years ago, based in Florida. And he really came up with this concept of expertise. And what Ericsson talks about is that when you go through training, initially there's obviously hurdles, a lot of learning curves. And towards the end of your fellowship, you might reach a level of competence and be comfortable in your set of skills. But then the challenge actually presents itself in that we can tend to become sort of automated and not push ourselves to become better. And Ericsson really promoted this idea that in order for one to become an expert, you need to set yourself new challenges and continue to have a growth mindset. There's an acronym that came along in some of the literature, which is PERFECT, which talks about having a purpose to your activities, setting the environment to perform this. What does it represent? So what's your end point? What's the goal? Critically feedback, and Tom Campbell will talk to you a bit about this. Experimentation or experience. You have to be curious. So how do we translate this into a real-world environment? And that experience in itself should then trigger some new learning points and new targets. And I'm a big tennis fan. And if you think about these two fellows, Roger Federer and Rafa Nadal, they're obviously the best tennis players in the world, legendary players, but they still go out every day, despite being the best players in the world, and practice. Why? Why do they have a coach? They don't need a coach. They know how to hit a ball. It's because they're constantly trying to improve their performance, every 1%, trying to get better every day. And in many ways, as surgeons, we should actually strive for the same thing, irrespective of your level of experience. So with this return to surgery course, it was embedded in several modules or elements. There was theoretical aspects. We integrated virtual reality into this course, having reflective exercises, supervised live surgery, again, reflection on that experience, and finally an audit of your real cases as one returned to live surgery. In the theoretical component, Dr. Jacqueline Belts and I developed a series of podcasts, which is freely accessible through the GenI podcast platform. And this gave some context to the psychological principles of surgical simulation and returning to surgery. After that, we encouraged each individual participant to look through their own surgical videos and perform a reflective exercise. And you go, well, what are we reflecting on? So we encouraged them to use the International Council of Ophthalmology has an objective structured cataract assessment rubric, and go back and record and mark their own surgery. And this got an individual thinking about the individual steps of surgery. And it's an objective rubric, so there's no scope for biases here. That's what it looks like. This is accessible through the ICO website, and you can see for every key step of cataract surgery, there's some guidance on how to score. And so this gets you in thinking about those critical thinking of the individual steps of surgery, even before you've hit the simulator again. Then we were privileged in Melbourne to have 2 simulators, and the next phase of the course was to have the individual participate in a simulation activity. And Nick has shown some footage of this. But we actually developed a specific module on the IC simulator. And this module had, as you can see there, targeting specific skill sets of cataract surgery from the rhexis all the way to managing complications, including an anterior vitrectomy task. And an individual will have to reach certain thresholds to pass these individual aspects of their virtual reality experience. And just to show, so this is one of our registrars practicing on a white cataract, doing the capsular excess sustained with vision blue, and going from there. So you can see how it's actually not only teaching the motor skills or refamiliarizing with the motor skills, but also the pre-operative elements required in planning. Complication training was simulating anterior vitrectomy, and so that is also possible in the simulator. So you can see how powerful this modality is. After the mandatory simulation, it was next task was the supervised live surgery, which could be performed in the registrar's case with obviously a surgical supervisor, but for our consultants and fellows with a trusted colleague, even a near peer learning platform. And again, the feedback was based on the ICO rubric. And there was reflection both in the moment and an opportunity to feedback afterwards. And further reflective tasks. So this is one of the registrars and I going through their surgical video. And this was quite a nice way to actually close the loop of learning points. We know that in addition to motor skills, there are ways to assess cognitive skills, and the non-technical skills in surgery is a framework that's been implemented across the UK. And this is what the NOTS framework looks like. Situation awareness, decision-making, communication, teamwork, and leadership. And these are all equally important aspects as much as technical skills in planning and ensuring a good outcome on the day of theatre. And finally, a self-reflective activity. So that's a framework that we've developed using return to surgery as an example. And this is, I'm pleased to say, all our trainees in Victoria went through the return to surgery program, and we've had also 19 consultants who've participated in this as a CPD activity. And I'd finally like to thank, obviously, my hospital, Dr. Jackie Belts, Associate Professor Kathy Green has been an incredible mentor for me, and all the registrars and trainees. So thank you. I would next like to introduce Dr. Jacqueline Belts. Dr. Belts is a corneal, refractive and cataract surgeon in Melbourne, and also the former Director of Training in Victoria and the current head of the Australian Society of Cataract and Refractive Surgeons. So thank you, Jackie.
Thank you, Rahul, and thank you for all of the talks so far. Thanks for being here. I'm going to talk about a particular program that we've just very recently started at the eye India in Victoria on presbyopia correction at the time of cataract surgery. And it's kind of to show you how we integrate some of the concepts that my colleagues have already discussed for a particular topic, and also to show you that we don't just do virtual reality, although we do really enjoy that. These are my financial disclosures. So as you've heard, in Victoria, we've implemented a new training program since 2018 when Nick was in first year. And this training program integrates virtual reality as well as wet and dry lab and all other techniques of training. From 2019, we've also been training with high-performance psychologists, and this video that's playing is a psychology practice that we're associated with in Melbourne, and they do a lot of sports psychology, but they also help us in training the mindsets and behaviours that we need as high-performing surgeons. The second video here shows Carmel Crock, who's one of our best consultants and emergency physicians at the eye India, doing some professional attributes training and behavioural training at the eye India. And then, of course, we have the virtual reality training that we've seen already this morning, and the in theatre, real life supervised surgical training. That, of course, is still critically important. But we can utilise all or some of these different training techniques to teach different strategies. And in this case that I'm going to show you today, it's about presbyopia correction or refractive cataract surgery. Whenever we introduce something new in training in Victoria, we're pretty careful about it, and we make sure to undergo a thorough needs assessment, because really every time I've asked a trainee or a young surgeon if, would you like us to teach you this, they're always going to say yes, because they're eager and they're keen to learn and they want to know everything. But actually, the time's really critical, their energy is finite, and we don't want to be wasting their time on anything that isn't really important. So we look with a very critical eye. However, the needs of our patients are increasing significantly, and there's a significant gap in cataract surgery outcomes between private and public patients that is emerging. We really also think that in terms of cataract surgery outcomes, the outcomes depend a lot more on just having access to lenses, which has often been described as the reason that we can't do this type of training in public, when actually it's fairly easy to get the lenses, but it's fairly difficult to initiate the training that's required to be successful with those lenses. Specifically, when looking at the needs, we can look at the curriculum standards, and of course there are refractive outcomes measures in our curriculum standards. But the thing that really drew my attention to this need was a question that was on the race exam a few years ago, and it was basically about presbyopia solutions for a patient who wanted to decrease their dependency on glasses post-cataract surgery. And actually, to my surprise, even though I was director of training then, the question was really poorly done nationwide. And it wasn't that it needed to be complicated, it's just that these topics weren't being covered at all in training. And this is what really highlighted the need to me. Our trainees in Victoria, as you've heard from Nick's presentation and the others, are already approaching Dreyfus level of competency by third year. They do a lot of structured, dedicated training in first and second year, and by third year, they're pretty good with cataract surgery. And so we can start thinking about these more advanced techniques. And I really also considered the presbyopia course that I'm describing to you as an opportunity to teach about other things as well: patient discussions, patient outcomes, how to speak to patients that are not happy post-operatively, and an opportunity to also improve their training in management of astigmatism. Rahul has introduced Gen I really nicely, which is a platform that we started at the Eye India Hospital in 2019 to deliver some of this high-performance cataract surgery training. And through Gen I and the Eye India Hospital for presbyopia correction, we created an online and real-life education package that's aimed at developing the knowledge and skills required to achieve excellent results with presbyopia correction. We execute this program at the Eye India Hospital in Victoria, which has taken also support from them. And speaking of support with any of these new programs, I do need to think about the different stakeholders that are involved. And in a multi-layered institution such as a public hospital, there are many stakeholders other than just the patient and the surgeon. Of course, there's extra chair time to explain these things to patients, as we're used to from our private practice, but not necessarily allocated in the public hospital. And there's also extra effort required from our orthoptists and our team, and therefore the throughput through clinic will be slower. And this all needs to be considered from the beginning, or we run into hurdles later on. Of course, any program should have learning objectives. If you want to know what they are, you can see them online, but we consider these from the start. We don't just start doing cases. There's several inputs, and the most important, I guess, as with anything that we want to start, especially in a public hospital, we need money and we need time, but there are other things as well that I'll cover in a little bit more detail. The process of this course is that each trainee will have access to this course whilst they're an advanced trainee. So that means that third and fourth year registrars can do this course once during their training at a time that they're rostered to the Eye India Hospital. And we're able to do this because training in Victoria is centralised. So every trainee in Victoria comes through the Eye India Hospital at some point in third and fourth year. The actual components of the course are that it starts out as a digital course that the trainees can commence at any time that they like. And then once they get to a certain level, they execute some real life cases and analyse their results. So first of all, there's 2 videos that they watch. There's some recommended pre-reading. There's a 7-episode podcast series trying to unravel and discuss the nuance that's important with presbyopia correction. There are virtual cases that they do online to help them with case selection and who's right for which lens. And then there's a lot of help in terms of choosing and planning their cases that all, of course, gets double-checked before the cases are done. But once we get through all of that, the trainee finds their own cases in clinic, consents them for surgery, gets those cases approved by either myself or the advanced cataract fellow who reports to me, and they can do 6 eyes of 3 patients with a number of different options. We then have a fairly significant assessment and evaluation component of this course to make sure that it's valuable and that they're really learning. So just in case anyone wants to see the course, you can just go to geni.org.au and look under online learning and you'll find the course. And you can see that they just progress through like any other digital course that you might have done, especially during the pandemic. I mentioned assessment, and it is really important, and this certainly isn't a make or break assessment, but we really need to make sure that the learning is valuable and that the trainees are learning. So there's different assessment components that are scattered throughout the whole course. And then after that, we also have a prize. We like to do this in Victoria, or our trainees don't buy in, right, Rahul? So to make them excited, and to hopefully further their learning, we offer a prize for one of the trainees to attend a national or international meeting to further their education on refractive cataract surgery. So hopefully this will help them to be enthused about the topic throughout their career, not just their training. Evaluation, this is a new course. We've only just released it over the last 4 or 5 months, but evaluation will continue to be really important because this needs to be iterative, and we will continue to improve it all the time. So there's different things that we'll be looking at to make sure that that happens. Some things have been easy and some things have been difficult. Initiating this course, as it turned out, it was fairly easy to come up with the concept after that exam question had been done quite poorly. And it was fairly easy to get support in terms of educational grants because everybody wants to learn refractive cataract surgery and there's a lot of people that want to support us in doing that. The challenges have related to creating the course and keeping it contained because there's obviously so much that could be included, but also the buy-in of not the trainees always buy in, but colleagues and other departments of the hospital, and we've had to really work through those in a positive manner. And the current issue really relates to case selection. We have, for probably obvious reasons, been fairly careful with our case selection because if we create a whole lot of problems in the public hospital, then the course won't be able to continue. We need to have excellent patient outcomes because, of course, we want our patients to be very happy and satisfied, but also if we have too many problems or returns to surgery, then our course will be cancelled. So the inclusion criteria are fairly inflexible, and that can make it difficult for the trainees to find cases, but we're working through that and the first cases are starting to come through now, and hopefully this will be a very positive advancement for the learning of our advanced trainees and fellows in the future. If anybody would like to have access to the course for their own learning or for your own trainees, I'll just mention again that it's freely available online, and as you saw, we're trying to improve it all the time, so please feedback any suggestions, mistakes, improvements to me, and I'll update the course so it can keep getting better. Thank you very much.
Thanks, Jackie. I'd next like to introduce Dr. Thomas Campbell. Tom is a consultant ophthalmologist, has affiliations with the Sunshine Coast University, and has a PhD in cognitive neuroscience and one of our recent Victorian graduates. Thanks, Tom.
So I just wanted to give some overview of advances in feedback and the cognitive neuroscience around feedback and learning, and really nut down on some specific details about where I think both we as self-directed learners, but also as educators, can try to improve our practice and improve the kind of feedback that we're giving to the people who are learning off us. So feedback and learning are terms that are just bandied around all the time, and often they're used in quite amorphous buzzword-like ways, and it's really hard to kind of understand exactly what people mean when they say that they're giving feedback or that their registrars are learning. There were more than 14,000 publications reviewed in one recent review, of which 10,000 focused on feedback in medical education. And in this review, they reviewed the 810 previous review articles on feedback in medical education. So before trying to come up with a really clever definition of learning, I think it's really best to use Tom Mitchell's definition of learning, which is essentially learning is what has occurred when our performance improves with increased experience. So I'll just say that again. So as we have more experience and our performance improves, learning has occurred. And that's not always the case, right? So I have more experience as a driver than I did 10 years ago, but I'm definitely not a better driver than I was 10 years ago. I don't think anyone in the room is. Many of the things that we do on a day-to-day basis, we improve and then we plateau. And that can be just the everyday skills, the things that we do as kind of automated behaviors. But a lot of our really important skills that we should be expert at, we also have this arrested development. And some of the previous speakers have spoken about the kind of steps we can take towards improving our performance continually as we get more and more experience. And deliberate practice and feedback certainly feed into that. Quality feedback is the basis of all learning, John Hattie, the educationalist, said. And it's debated in sort of neuroscience circles whether it is possible, in fact, to have learning without feedback, and there's probably some really isolated cases of it, but really feedback is what drives learning. And feedback is essentially what happens when the output of a system is fed back into the system. And if that feedback back into the system improves the output of that system, learning is said to have occurred. So Norbert Wiener said that in the 1950s when he was inventing the field of cybernetics. We still have a really poor concept of what actually is going on. So just go over it. So there's a system. That can be a person, that can be a machine learning algorithm. And what that system does is generates two things. It generates the behavior, but also a prediction about what that behavior should look like. That's the goal. That's what we expect to happen in the world. It then compares those two things, what they actually did and what they should have done. And that error signal is then fed back into the system to try to improve the output of the system. And the system in this case we're talking about is our trainees or ourselves, because we're all self-directed as learners. We should all be trying to improve our performance throughout our careers. So from a sort of andragogical or pedagogical perspective, there's four really important components to feedback. That's observation of performance, evaluation of performance, and then guidance to the next level of performance, and then a meta step, which is facilitation of performance improvement, which is trying to get the person to get better at doing these steps as well. So to get better, not just the task, but get better at learning at getting better at tasks. Now, we're all really good at this step, right? We watch people first years doing cataract surgery, and we're all very confident in evaluating the outcome as being very poor. You are not doing well. What's really difficult is going from what they've done to give them concrete steps to move towards getting better at surgery. That's what I really want to highlight, that one of the most fundamental tasks that we have as educators is in providing a really vivid, granular, shared mental model between us and the learner about what the expected outcome should be. If the expected outcome for a learner is operating as well as the cataract surgeons that they see on YouTube, the gulf between their performance and the goal of performance is so vast that that error signal is not able to be usefully fed back into their learning. So this is my brother-in-law. He's an educationalist. He teaches pilots how to fly for a large airline in the UK. And he and I discuss this all the time, and I said that I would give him some credit in the talk, so I took a picture of him surfing really badly. So that's me at the top, definitely better than my brother-in-law. But if you gave him that picture and said, this is the expected level of performance, this is where you're at right now, take steps to get between there, surfing half a foot Currumbin, and surfing really good surf, it's just too big a gulf. So what we need is smart kind of goals. Those are specific, measurable, achievable, relevant goals that are time-bound. So one of the things that I try to concentrate on when giving feedback in surgery is in generating this shared mental model, is instead of saying, make your surgery better, one of the bits of feedback I was given by one of my mentors was, you should be more elegant as a surgeon. Now that's certainly a very vivid description of my surgery, but it wasn't that useful at generating better performance. So instead of saying you should improve your capsular rhexis, how about saying in this list, the goal is to perform 6 perfectly circular rhexi centered on the visual axis, each measuring exactly 5.5 millimeters. Now that's a really smart, specific goal that is relevant and achievable by most registrars, and it gives them something, a really vivid, granular mental model, which they can compare their behavior to the expected outcome. So are their rhexi too big? Are they off-centered off the visual axis? And so this is the step that I think that we should really concentrate more on as educators, is in generating those really vivid goals that we can share with our registrars about what their behavior should look like. And it's really important that that shared mental model varies with the level of the registrar. Because if we don't keep raising the level of the expected performance, we get to the point where we have arrested development because there is no error signal anymore. Most good surgeons can start doing perfectly circular rhexi that measure the same diameter and are centered on the visual axis. What we then need to do is generate the next level of expected performance. And each of those levels should be just challenging enough to continually spur increased performance. And the second component that I really want to highlight is in this facilitation of performance improvement. So this is the meta task, that making our learners better at being learners, better at using feedback, better at taking feedback, better at seeking out feedback from their educators. Because feedback is useless if it isn't used to spark a dialogue about the feedback given and what might be done with it. This isn't just you delivering information from on high, but it should be a really involved process between you and the person that you're trying to teach, and helping them interact and optimize their use of feedback, how they try to assess feedback from you, how they integrate that feedback into their day-to-day life. And then by improving this level of process, you can transition to being a self-directed learner. So to summarize, I think the really important thing in that feedback is not just a unidirectional process in which information is delivered from an expert to a beginner, but a dialogue between two people about refinements of shared mental models of expected outcomes and how the actual observed behavior differs from that. It's learner-centered, and it is that learner-centeredness means that the goals and that shared mental model has to vary between each of the different trainees that you're training and vary across time as their performance improves or changes across time. And because this is such an educational alliance, it's really important that we engender trust and respect between the trainee and the trainer, because it's an opportunity to really hurt people and set their learning back if we give feedback in an inappropriate kind of way. And so it's really important that we have that collaborative model. And in the facilitation of the improvement of learning, and also in our own behavior, we need to consider that this meta aspect of using feedback to improve our abilities as self-directed learners in our lifelong pursuit of expertise, and as Erickson has pointed out. So I just wanted to thank all the other speakers and then to open the floor for questions across each of the different talks. Thank you.
So there's two microphones, one down the front and one up on the higher level, if anybody in the audience has a question for the panel. I might kick off. Tom, I've got a question for you. So you talked about giving specific, measurable, achievable, etc., being smart. What about some practical tips? So, you're supervising a theatre list with the registrar. For supervisors, tips such as setting aside time, like when do you give feedback? In the moment, at the end of the list, a week later? Any thoughts on that?
Yeah, so what I tell trainees that I'm supervising is that I will spend more time with them before the list than after the list, and the feedback will be between the cases rather than bulk feedback at the end of the list, because I think it's really important that the feedback should be in real time and give the trainee an opportunity to integrate that feedback into their behavior straight away. So at the end of the first case, I'd say, you've done really well. Here are two really specific things that I think we should concentrate on. And that builds into what we've done before the list, is that I have asked the trainee where they are, asked them about what their goals of learning are, and then together we have generated a model about what their behavior should look like and some really specific measurable goals. Then I would discuss them after each case. And at the end of the list, most of the discussion's already done, and they might debrief a little bit, but it's done in real time or before the list, most of the feedback.
I really agree with that, and I think it's an excellent approach because every case is a learning opportunity. But I just wanted to point out that this is different to doing the forms, that trainees often come back to us a week later, or quite a bit of time's elapsed since the case was done. And doing the forms is not the same as feedback. The form, if you're doing the form at the end of the college form, at the end of a session, it might be utilised as one of the tools of that feedback, but it's not the same thing, right?
George, you have a question?
Thank you very much, everyone. It's been amazing. I just got a question in terms about feedback. We know that it can be very theoretical, and my experience in higher education teaching students, we discovered a few years ago that many of them don't understand what is feedback, because the students' surveys, they were saying, no, we didn't receive feedback. And we realized that we need to mention every time that we provide feedback, saying, okay, time for feedback. And sort of, I wonder if it would be useful for as Transco, staff, to develop some simple modules for trainees to teach them what is feedback, what is good feedback, how they can take feedback. And also because being also cultural sensitive as well, because how you can provide and receive feedback when you belong to a different culture.
Thanks. There's some really important topics there. The strategy that Tom was talking about is a good educational tool, because if it becomes normalised that there's feedback at the end of every case, then it does become expected. But one thing that you highlighted is really important to say, and it's been shown in the literature as important, is that you do need to say, this is your feedback, or now we will now I will give you some feedback. Because without actually saying the word, the perception of the learner is often that I didn't get any feedback. So it's not just the process of doing it. And I think that it's been shown that the best way to do it is to just say it. This is your feedback.
And Jackie, one thing I'd just add to that is that there's a negative connotation with the term feedback. But what we know is that from studies and theories of programmatic assessment, that really feedback should be something that's integrated in routine daily experience. So positive and negative, and setting aside that time. If somebody's done something well, that's excellent. But people tend to remember the negative experiences. But if it's formalized as part of a routine expectation, then it becomes less intimidating for the for the trainee and also a part of a routine practice for the supervisor.
I'll just say as a fellow as well, the time out between cases becomes a bit more informal and conversational, and you have a different relationship with your trainers. Whereas in first year, you're sort of expecting feedback, quite formal feedback between each case. And now you sort of sit down and go, yeah, that went okay, that's fine. But we don't set aside a time and say, this is time for feedback, because it's a lot more informal. And maybe that's something that I might have to prompt my consultants to be, this is our feedback time. What feedback do you have for me? Yeah, it's an interesting question, yeah.
It's a good idea, Nick. And also next year, when you're not a fellow anymore, to not forget about the SMART goals that Tom was talking about. And I still do that. I go into theatre. Today I'm going to work on my capsulorhexis or whatever it is that I'm trying to improve. And even though there's nobody there to give feedback, you can still utilise the same kind of strategy.
Thanks, guys, for a great talk. Just one comment and a question. So the comment is, I suppose, just about the availability of those programs like coming back after a break from cataract surgery, and a couple of groups that might really benefit being people coming back from maternity leave and also fellowships that are not surgical based. So just, knowing, getting the message out that that is available, and, whether or not people in those groups have access to the simulator as well. Because, I think a lot of people don't know about it, even though we all know that that is there for the trainees. And obviously, as a supervisor now, I think it's made an amazing difference. So even surveying the supervising consultants in theatre to see if they've made a difference might, just help you give an extra graph to show what an amazing difference it's made. So thank you, Jackie, and now Rahul, for bringing that on. And the other comment is just in terms of giving feedback and these kind of tips. There's so many people involved in supervising, and obviously, there's lots of sessions on, not everybody gets to hear these talks. So whether or not in future doing something like a breakfast for the supervisors of trainees or something like that, where some of these topics could be covered, might give you a bigger audience to get some of these really important messages out. Thanks.
Thank you. There's so many good points there, and I agree there's a lot of space for more train-the-trainer type activities, and we'd like to be involved in those for sure and develop more resources there. In relation to the returning to surgery after a break, we actually, Rahul and I did have this program on our mind before the pandemic for some of those circumstances that you described, returning after parental leave, fellowships as you described, but even after just holidays or exams, things like that, when you're a trainee, can make quite an impact. So the program is available, and it's available online. But there is one thing that we might not have mentioned so much, and that didn't really come up, in that it's not just having access to the simulator that's important. We did have a structured course on the simulator, but the simulator time was supervised. And I really strongly advocate for that, because there's two real ways to use this technology. You can just have it there and go and use it when you want, or you can have a structured way to learn with somebody there giving you feedback and help and advice. And so with our return to surgery program, we did have that live trainer there at the time of the simulation training, and it was also rostered and paid during work time. We did achieve CPD points from Ransco, but what we did not have is the time resource to take all of our colleagues through the program. But the online and digital components are certainly available online for anybody.
And just to add to that, our college portal, the online portal, does have a ophthalmic education, train the trainer, a series of modules, which I'd encourage every supervisor in the room to have a look at. And the argument that sometimes comes up to me is, well, in Victoria you have all these resources, we can't do that in another state. So I would respond to that by just saying, having conversations with your your colleagues and those who are involved in registrar training and developing a local community of practice of like-minded ophthalmic educators, just like we've been doing in Melbourne. And that then suddenly your faculty expands and suddenly you do have people who are interested in near-peer learning and supervising. So start that conversation and see where it takes you. Any other questions? All right, well, I'd just like to thank all of you for attending. I know it's Monday afternoon and a beautiful sunny day, so I do appreciate all of you and those who are online listening in. I'd like to thank all my panelists for sparing their time and your individual contributions have been really insightful, and I've really enjoyed working and chairing this session. Thank you to the Congress organisers for allowing us to have this session. Thanks.